let's continue with part 4 of our poisoning case. And so let's summarize what we know so far. We have a 29-year-old male with altered mental status after suspected overdose of lorazepam, acetaminophen, oxycodone, and alcohol. He's unresponsive with a heart rate of 60, respiratory rate of 6, blood pressure of 90/60, and we intervened or acted with intubation, IV fluids, and placing the patient on a cardiac monitor. We talked to family and EMS and friends and found that a suicide note was found. The time of ingestion of these medications is unknown, and on exam we found an opioid and sedative hypnotic toxidrome. Let's think about some red flags we still need to keep in mind about this patient. The patient also took acetaminophen, which is a poison in itself. We'll talk about how we should treat this in a few slides. The patient also had a suicide attempt, so this is something that may require psychiatry to become involved. And we don't have a full history from this patient. He doesn't look like he had any trauma, but we don't know exactly what happened to the patient other than he was found with pills next to him. And so let's talk about each red flag one at a time. The first we're going to talk about is the incomplete history. So like I mentioned before, it's important to have a full differential for altered mental status. Right now, we know that poisoning or ingestion is at the very top of our differential. However, there's still other things we haven't completely ruled out yet. Let's think about a differential diagnosis for this patient and go through it one at a time. So if we think about alcohol, opiates, and poisoning, we have some findings that support this. We found a suicide note. The patient had empty bottles next to him and was found altered on the floor. It's also possible, though, that he could have an electrolyte disturbance. He's been drinking alcohol, although going against this is the patient has a normal EKG with normal intervals and normal T waves and no U waves. On our differential is uremia. It's possible the patient could have ingested something that was nephrotoxic, but he doesn't have any history of kidney problems. It's possible he could have had some sort of trauma or a subarachnoid hemorrhage. We don't have any good history on him. He's intoxicated, but again, he doesn't have any physical signs of trauma on exam. Infection's also possible, but less likely given that he's afebrile in the emergency department, was well appearing 24 hours ago. Encephalopathy is possible. We don't have any good history, but he has no clinical signs of herpes. He's not hypertensive. He hadn't been complaining of a headache, and his neck does not appear stiff on exam. A stroke or TIA is possible, but unlikely given that this patient is young and healthy. And a space-occupying lesion is possible. He has pinpoint pupils. This could indicate some sort of herniation. So if we change the text to show which ones are most likely, we narrow it down to alcohol, opiates, and poisoning, electrolyte disturbance, trauma, or space-occupying lesion. And so to evaluate our differential diagnosis, we now want to enact some diagnostic testing and therapeutic interventions. And so what tests should we order on this patient? We should order a CBC, a basic metabolic panel, LFTs, serum osms, a salicylate level, an acetaminophen level, an EKG, which we've also gotten already. It's also important for altered mental status patients to get a CT brain. But there are a few things on here that are questionable. So a urine drug screen or alcohol level is questionably useful in altered mental status patients. We know for a fact that the patient was drinking alcohol. We also know that the patient probably ingested some drugs. We know he's altered. The urine drug screen doesn't necessarily tell us what the patient currently took or the current state of the patient. What it tells us is that the patient has been exposed to these drugs sometime in the recent future. Banking on the urine drug screen for a patient with altered mental status could lead you to miss other diagnoses. An alcohol level, while potentially useful, doesn't necessarily rule out other causes of altered mental status. Usually you can tell if a patient is intoxicated on physical exam, and an alcohol level alone doesn't guide you to how intoxicated clinically the patient is. And so it's important to remember that patients with altered mental status should have a CT brain unless there is a very clear history as to why they are altered. It's also important to remember that there is significant controversy over the utility of urine drug screens and alcohol levels. They may be ordered, but it's important to utilize them correctly. And then what about an MRI or an EEG? Those tests may be done on an altered patient if no other reason is found, but these are generally done as an inpatient and not in the emergency department. What about GI decontamination? So there's 6 main methods of GI decontamination: ipecac syrup, single-dose activated charcoal, multi-dose activated charcoal, cathartics, whole bowel irrigation, and gastric lavage. In general, ipecac syrup and cathartics are never recommended anymore. The other 4 have utility, but only in certain instances. So what about single-dose activated charcoal? This is indicated for a toxic ingestion less than 60 minutes ago, and it's contraindicated if the patient's unable to protect his airway, if it's a caustic ingestion, or if the patient has any evidence of bowel obstruction. So in our patient, should he get single-dose activated charcoal? The answer is no. We don't know when he ingested this medication. We did protect his airway by intubating him, so he doesn't have any contraindications to this. However, it's unlikely to be useful at this point in time. What about multi-dose activated charcoal? This is for suspected or confirmed life-threatening carbamazepine, dapsone, phenobarbital, quinine, or theophylline ingestions. The contraindications are the same as for single-dose activated charcoal. What about our patient? He should not get multi-dose activated charcoal because we don't suspect he took any of these medications. What about whole bowel irrigation? So this is used primarily for sustained release substances, iron, or body packers. It's contraindicated in patients with bowel obstruction or perforation, hemodynamic instability, intractable vomiting, or compromised airway reflexes unless they're intubated. In our patient, we don't suspect he took iron, body packing, or any sustained release substance, so he would not receive whole bowel irrigation. And then finally, gastric lavage. This is very, very rarely used. It's only used for massive ingestions of toxic drugs that occurred less than 60 minutes prior to arrival. The contraindications are loss of protective airway reflexes unless they're intubated, caustic substances or hydrocarbons, and risk of GI hemorrhage. This requires putting a large NG tube down the patient's esophagus. There's a risk of perforation, and it should only be done for extremely toxic drugs taken in the last 60 minutes. In our patient, we definitely would not perform gastric lavage. Again, another point of caution is gastric lavage has very limited, if any, utility and should not be done routinely. And so let's go over the diagnostic test results that we did get on this patient, since we've realized that he's not a candidate for bowel decontamination. We get a CBC that's within normal limits, a basic metabolic panel that's within normal limits, LFTs that show an elevated AST and ALT between 4 and 5,000, a total bilirubin that's elevated to 5.4, a direct bilirubin that's elevated to 2.1, a Tylenol level that's elevated to 86, a salicylate level that's normal. Suppose in this patient you did get a urine drug screen and it's positive for benzodiazepines, opiates, and marijuana. And suppose you did get an alcohol level, which is 240. His serum osms are 289. And let's talk now a little bit about why it's important to get serum osms on toxicology patients. He also has a CT brain that was normal. And so serum osms are important because of the Osmol Gap. So toxic alcohols like methanol, ethylene glycol, and isopropyl alcohol have elevated osmol gaps. Acetone and ethanol can also lead to an elevated osmol gap. It's important to calculate the osmol gap, which is 2 times the sodium plus BUN divided by 2.8 plus glucose over 18 plus ethanol level divided by 4.6. You take the osmol gap the osmol gap is the serum osmols that you order in the laboratory value minus your calculated osms using the formula above. A normal osmol gap is less than 10. And so why are toxic alcohols important? So methanol has an anion gap, seen on laboratory studies, as well as an elevated osmol gap. Methanol without treatment can lead to blindness. Ethylene glycol, you'll see an elevated anion gap plus an elevated osmol gap, and this can lead to kidney failure. Isopropyl alcohol, you'll see a normal anion gap, but an elevated osmol gap. Isopropyl alcohol ingestions are usually self-limited, but sometimes can have GI effects. The treatment for toxic alcohols is fomepizole. This is the antidote. So it's important to recognize these early to prevent blindness and kidney failure in those with methanol and ethylene glycol ingestions. That's why we calculate an osmol gap on all toxicology patients. And so this patient's osmol gap is normal. It's less than 10. And so now we want to think. We want to put what we know together. So we have a poisoning patient, potentially an electrolyte disturbance patient, and potentially a trauma patient. We want to figure out which one of these is the absolute diagnosis for this patient. We know that he was taking benzodiazepines, opiates, alcohol, Tylenol or acetaminophen. We know he has elevated LFTs. He has a normal CT brain, making trauma unlikely, and a normal BMP, ruling out electrolyte disturbance. And so we've determined that this is for sure a poisoning patient. And so now we want to think about what kind of poisoning patient this is. We know he took opiates, benzodiazepines, acetaminophen, and ethanol. And we did this based on the fact that we know he took benzos, opiates, alcohol, and acetaminophen. And we know he has a normal osmol gap, so we've ruled out toxic alcohol ingestions. And so in summary, it's important to keep a broad differential when you have a limited history. You should always consider an intracranial process in a patient with altered mental status. And diagnostic studies can narrow your differential. A urine drug screen may be helpful, but be aware of false positives, false negatives, and how to use these correctly. And always consider toxic alcohols and calculate an osmol gap in a toxicology patient with altered mental status.